Good afternoon, everyone. Thank you all so much for carving out the time from the busy, incredibly busy time of year that I know you all are working through to be with us today. Certainly, as Caroline mentioned, we greatly appreciate you completing the polling, as it only helps us to improve the services that we offer to you. We have the privilege today of two guest speakers. We have Aloysius Cooper from the Mississippi SHIP program, and we got Rochelle Spinarski, one of our highly regarded consultants in the space. They're with us on the call today. Before we get started, we do have a brief update from our federal partners. So I want to give an opportunity for Krista to chime in here and share with us some really good, much awaited news that everyone can't wait for. So.
Thanks for that, Nick. Well, I hope it's good news and long awaited. So I had sent out an email about a week or so ago now, announcing the FY24 NCC guidance had been made available. So as you know, that opens in EHB on December 1st, but we like to try to send things out a little early for y'all to start working on them. So we sent out the instructions, the 2 work plans, the new deviations table, and the 2 hospital application forms. So for those of you that have been with us for a while, you're probably wondering, what about the 2 clunky spreadsheets that usually go with the NCC? And we are transitioning all of that over to our new Salesforce system. And so that's why that you see the 2 different due dates, the February 16th and the March 8th. So it is our expectation that you'll have all of your information gathered, completed, and entered into EHB by February 16th. And then when the new system opens, and this is just related to the development process, it doesn't open until February 23rd. On that date, you'll go in and you'll enter all of your hospital funding and activities information. That is due on March 8th. So stay tuned. We will have some testing coming up in January, some trainings in mid-February, right before it opens. We know that this also is around the same time you're working on your Flex application material. So we did try to be cognizant of that and reduce burden and avoid deadlines where we could, but we're hoping that by having everything ready to go now for this NCC, so that you can update your fiscal 23 activities and then enter your fiscal 24 activities, things will be much easier in the future in reporting and accounting for your hospital's activities. So thanks for the moment to chat about that. Please feel free to reach out to me if you have any questions about the NCC in general, or Salesforce, and then any questions about like templates or activities or anything can go to myself or SHIP TA as well. Just reach out to any one of us and we'll make sure it gets routed appropriately, and we will try our best to answer your questions. Back over to you, I think, Nick.
Excellent. Thank you so much, Krista, and for all of FORP's efforts in setting the SHIP grant programs up for success in the coming year. So we're definitely looking forward to that. Thank you all for completing the polling. We have got a mixed group here. We got across the board, confident to unfamiliar. So, and we've got a little more than half that's looking to hopefully implement consortium-based funding in the coming program year. So, excellent. With that being said, let me close out of here. All right. So without further ado, we've got a really key objectives today. We're hoping that you all take away from this conversation is that we hope that you are able to apply the knowledge that you gain through this webinar to really ultimately help you improve your state SHIP funding strategy. We hope that you are able to apply this to your work plan initiatives and really optimize those for your state smaller hospitals. And we hope that you develop an understanding of best practice and steps to implementing consortium-based SHIP funding strategy for your state. So we have a lot of great information to share here today, but first and foremost, we want to kind of level set and get us all on the same page as far as what a consortium even is. That certainly was a new term to me not long ago, and we have new coordinators and people that may have not had a chance to work in that capacity yet. So there's really the definition here being agreement, combination, or group as of companies formed to undertake an enterprise beyond resources of any one member is capable of doing. I actually like this second definition a little bit better, beyond what Webster's dictionary defines it. And I feel like this one really applies to what we're looking at here. And that consortium is companies or smaller hospitals, two or more, that really come together to achieve a common goal. So that's really what we're looking at in the context of the SHIP grant. With that being said, we've got lots of different agencies that manage the SHIP grants around the entire country, and different approaches to how the coordinators have to navigate that. So we're hoping you all walk away with some equipped to at least consider things that you have not previously before. First and foremost, we wanted to really weigh the pros and the cons of what a consortium-based funding can and can't do for you. Certainly, I'm gonna switch my screen here so I can make sure I have my notes pulled up. Understand utilization of consortium-based funding for SHIP grant program investments can offer various advantages and disadvantages to your program. Understanding pros and cons of consortium can help your state to make informed decisions regarding the best approach for use of funding. Here's some key comparison between these two, and the main kind of takeaways of each. So first pro we have here is enhanced resource pooling. So obviously it goes without saying, by pooling the finances for a consortium, inherently the health systems have access to more funding and, of course, additional expertise and technology, and really this can lead to more substantial investments for those hospitals than would otherwise be possible if they're doing it alone. Of course, it increases collaboration and networking among the various consortium members, and it really fosters this kind of network of knowledge exchange, leading to development of innovative approaches to really target and implement best practices tailored to the unique challenges faced by small rural hospitals in your state. These partnerships can also lead to long-term mutually beneficial relationships that support continuous improvement via ongoing peer support in the future. So it's really great for its long-term sustainability too. Improving access to specialized service and service delivery. A big pro to this is that consortium-based funding can facilitate provisions of specialized healthcare services and technology that may not otherwise be possible or accessible to rural hospitals. The combined efforts of multiple organizations enable improvement of service delivery offerings, including enhancing chronic care management, preventative care, mental and behavioral health services, improved case management, and even community outreach initiatives designed to meet specific needs of the target populations that your state is facing. Of course, we got increased flexibility and adaptability. Consortia are often more flexible and adaptable in responding to dynamic healthcare changes and really changing community needs. Combined resources and expertise of multiple organizations enable consortia to quickly adapt their strategies and programs to address emerging healthcare issues such as public health emergencies, health disparities, and of course, evolving policies. So the combined group effort really helps position them up for success in that. We have enhanced advocacy and influence. This one's huge too. We've got collaborative healthcare consortia have a stronger collective voice and influence in advocating for policy changes, not just the state, but national level. And of course, the direction of the funding allocations leads to healthcare reforms that support the states, regional, and even national level. This increased advocacy power from a consortium group can help shape healthcare policies and regulations better serve the needs of rural small rural hospitals in the future, and also inherently promote equitable access to healthcare. So great stuff there. We got risk sharing. So we talk about risk a lot here in the program, but ultimately by sharing risk among consortium members, the burden of investing in a specific activity is distributed, reducing the potential negative impact on a single organization in the case of unforeseen challenges or obstacles that may arise. And we have improved sustainability. Consortium-based funding promotes sustainability of healthcare initiatives by fostering a culture of shared responsibility and accountability among participating health systems. This collaborative approach encourages long-term planning, efficient utilization of resources, and develops a sustainable healthcare model that are better equipped to withstand economic, social, and environmental challenges over time. So a lot of pros to why consortiums are really high value for rural hospitals. The cons are, of course, there's two sides of every coin here. The cons are there could be complex decision-making processes with consortiums. So in a consortium, decision-making can become complex because you've got multiple stakeholders in health systems weighing in on potential what priorities or action planning it looks like. And they all have their inherent own subcultures within their organizations. This complexity can potentially lead to delays or disagreements in the best approach to implement operational improvement strategies. We also have resource allocation challenges. So of course, we want to have equitable and fair funding. The hospitals all have their own specific funding, but in terms of resources that come out of a consortium, you want to make sure that we have a appropriate allocation of time, energy, and efforts for many partners or firms we bring into the consortium amongst your health systems. We also have dependency on collaboration. The success of consortium funding really relies heavily on the commitment and active participation from all the members. In cases where there's a lack of engagement or commitment among consortium participants, or lack of commitment among participants, the effectiveness and sustainability of the investment could potentially be compromised. So we want to ensure that's the kind of culture we're building. A potential power imbalance. So power imbalances within consortium, especially if one or more members are significantly more outspoken than others, can lead to unequal decision-making, authority, and prioritization of resource allocations throughout that project. So certainly want to hear the voices and opinion from everyone involved in it. We've got accountability and governance issues. We want to ensure that we establish clear accountability mechanisms and government structures within a consortium. It can be challenging, so lack of proper accountability measures may result in inefficiencies or lack of transparency, potentially hindering success of an investment activity. So all of those kind of fall back to the programmatic management and many of the things that you all have already been studying and are developing systems and process to affect now. So certainly more than equipped to handle those successfully. So we got a couple more slides here. I don't want to sit here. I know no one came today to hear me talk, so I'm going to try to get through these as fast as I can, and then we'll get into our group discussion and we'll really unpack, like where the rubber meets the road and how do I get there? How do we implement the things that sound good on paper? So bear with me just a minute and we'll get right to that. These are just basically aggregated what the industry tells us of here's some things to consider if you are going to structure or implement a consortium. So bear with me just a minute. I'll get through these as quick as I can, and then we'll get to our open discussion. All right, so we got best practices here. Utilization of consortium-based funding for the SHIP grant can be an effective strategy for enhancing capabilities of your rural hospital systems. By collaborating with various organizations and stakeholders, these systems can access additional resources, expertise, and technology that may not be available to them otherwise. So here's a few best practices related to this consortium that are certainly worth considering. Number one, we got the strategic partnerships. Fostering strong partnerships is mission critical for all. On their island alone by themselves, not affiliated with a system, is a real struggle for the hospitals out there if they're not developing partnerships. and collaborating at this point. So a consortium gives the opportunity to do that with a consensus of the things they're oriented to work together on. So really great way of fostering that and forming that ongoing partnership that will continue to support each other moving forward. We a consortium also, and you all know from this reporting and evaluation side of it, a consortium has the means to establish very clear objectives. So defining clear and achievable objectives for consortia and for each participating small hospital, and you can have a developed charter or comprehensive plan outlining roles and responsibilities of each member to ensure effective coordination and execution of the project activities. Effective communication. So we throughout this, we're going to want to ensure that we maintain open and effective communication channels among consortium members to ensure that everyone is informed and engaged throughout the process. Regular meetings, progress updates, feedback sessions can help in resolving any issues or challenges that may arise during the project life cycle. We got effective resource allocation. So developing a transparent process for allocating the resources, including the funding, your subject matter experts, and their assessments and the technology they're using to ensure that each member's needs and priorities are addressed. Implementing a fair and equitable distribution system that promotes collaboration and maximizes the impact of the grants fund used. Compliance with regulations. So partner with agencies that stay updated with the latest healthcare regulations and compliance requirements to ensure that the consortium operates within the legal framework and establishes internal controls and monitoring mechanisms to identify and prevent any potential compliance issues and maintain integrity throughout the process. Of course, we're going to implement a robust system that monitors and evaluates the impact of consortium investment activities, and we're going to define key performance indicators and metrics to address the effectiveness and success of the consortium project, and use that data to make informed decisions for future SHIP grant strategies. So really great opportunity there to really pool and aggregate data and really make your life easier, not only reporting, but your long-term program strategic planning as well. We've got continuous learning and improvement. We want to encourage a culture of continuous learning and improvement within the consortia. We want to foster a positive environment that promotes innovation and knowledge sharing and best practice dissemination among the members and enhances performance and sustainability of the initiative long term. That was a lot. Any questions about the best practices? All right. You all are sharp. That's what I like to hear. We got just a couple more slides here. We'll hop into it, our open discussion. So okay, here we are, developing a strategy. So how are we going to actually implement this? So first off, a needs assessment. You all are privy to, or you have access to, a lot of excellent information from our partners and the agencies that are involved in the grant. So you've certainly that's our starting reference point, but you can't get around having an actual needs assessment based on what it is you really want to take a closer look at. So conducting a comprehensive needs assessment to identify specific challenges and gaps within a target healthcare sector, such as this, for example, like a statewide Medicare or MA plan denial management for your state. But understand, whatever that looks like, understanding specific needs of your hospitals will provide valuable insights into the areas that will be high value, ultimately high value to them for a consortium investment. So have to ask a few more questions, get everyone on the same page about what they identify as their highest need. And that certainly you can start your conversation with an agency that can provide consulting or assistance to address that through a consortium. We have identified stakeholders here, really all community partners, including healthcare organizations, government agencies, community leaders, nonprofits, and even potentially additional funding partners who can contribute to the consortium initiative. And if they're passionate about it, they will build strong partnerships, and really throughout the process will ultimately support not only success in this implementing this project, but really ongoing sustainability after the fact. We together, we want to ensure that we've got clear objectives and goals, define clear, achievable objectives and goals for your SHIP consortia. Will ensure the outputs and outcomes align with the identified needs of your health systems, and they're measurable, time-bound, realistic, and provide clear direction for the program's implementation and evaluation. We have the formation. Establish a consortium structure that outlines the roles and responsibilities for each, including the government structures, decision-making process, communication protocols, and ensuring effective collaboration and coordination among members. We have a funding strategy, of course, comprehensive funding strategy with consideration of future funding resources to ensure sustainability and ongoing support of the initiative. We've got a resource allocation plan. We want to make sure that we have outlined how the resources will be distributed among consortium members and allocated for all your hospitals that are participating. We have performance monitoring evaluation, implement robust monitoring evaluation framework to assess and progress and impact of consortium network funding activity. And we're going to define our KPIs and metrics that can help us evaluate the effectiveness of the investment activity and ultimately success of it. We've got capacity building training. We want to invest in capacity building and training to enhance the skills and knowledge not only of the healthcare workers within the consortium, but ultimately to help really change the systems themselves so it's transferable. We all know that, recruitment and retention is a challenge for these hospitals. So we want to do what we can through this consortium activity to evolve the entire system as a whole. So the processes, the systems, and their approach, its systemic changes is really valuable in the long haul, because people, if they retire, you don't want that to be a non-transferable adaptation. So this goes into the sustainability. We want to have a sustainability plan that outlines how the consortium network program will continue to operate and thrive beyond the initial funding period, identifying opportunities for ongoing engagement and partners beyond the year one of the activity. And of course, we got stakeholder engagement and communication. We're fostering open, effective communication channels, encouraging stakeholder engagement throughout with regular meetings, feedback sessions, as we mentioned earlier. So good stuff. And with that being said, we got a few questions here, and I will have to lean heavily on our guest speakers on the call for these, but certainly anyone on the call today, if you've actually been down this road, we'd love to hear it. If you got another perspective that maybe we don't bring up here, by all means, please come off mute and join the conversation with us. So first question we have here are, how are the consortiums currently being developed in your state? So with that, I will start with Illustrious, because she and I talked about her answer, and I think it's great because that was the reference I had earlier, only reference I had earlier. So please take us away, Illustrious. And Rochelle, if you please tell us what all you've seen, that'd be great too.
Well, good afternoon. Like I told Nick, we didn't ask for permission, but asked for forgiveness later type approach, meaning that we basically sent out an email to our hospitals letting them know that we would not be moving forward with individual sub-grant agreements, and that we will be moving forward with consortiums. Now, prior to this email going out, we reached out to our hospital association, because of course they know our hospitals better than anyone else in the state. We shared some ideas with them about how we would like to implement the consortium, what activities would be implemented, what that would look like for us, and how we wanted to be included, since this was our first time implementing consortium. We just based how many hospitals would participate in each consortium based on the hospital applications that were submitted. and along with our NCC at the beginning of the fiscal year. After that, we reached out to the hospital towards the end of the SHIP 22 fiscal year. Just said, hey, we'll be moving forward with the in partnership with the hospital association to implement a consortium-based activity planning project for the hospitals. And honestly, I didn't get any negative feedback from any of our hospitals. I was expecting some pushback, did not get any. So for us, the implementation piece has been going good so far because we didn't get any pushback for it.
That's great. Luscious. That's that was kind of the, here's what we're going to do. Is definitely an approach that many of the states have taken. And there's certainly there's constraints that may or may not allow that, but it's certainly a valid approach, and we'll get you there pretty quick if you have the means and capability to do it. What have all of you seen out there, Rochelle?
So good to see you, Alicious. I'm going to talk specifically about the state next door, so Louisiana. Alicious is from Mississippi. And in Louisiana, what we've been doing is really leveraging our needs assessment that we conduct as a part of the FLEX program each year. And that's specifically a quality improvement needs assessment. And so using the data from that needs assessment, then we have transitioned that into we've identified then, what critical access hospitals are in need of what and where some of those opportunities exist. We haven't established any formal consortiums where there's signed agreements specifically across those critical access hospitals where they're agreeing to formally be in something, but we've established more, I'll call them informal consortiums. So our latest one that we established was related to HCAPS, except it focuses on ED caps. We know that caps in general, all of the services within our facilities impact those HCAP scores. So every experience across the whole organization will impact what a patient says about any part of our organization. So we established an ED caps cohort, and it's a contract with one vendor where we are using the SHIP funding to actually pay for that ED caps for a set number of critical access hospitals who've all agreed to use the same vendor so that we have data, we can track things over time. And then we're leveraging the FLEX program to do the technical assistance, more of, we have regular meetings to move that ED caps project forward. So it's been a combination of using different resources, but also really getting those hospitals together to work on an initiative that can impact both sides of our programs, both on the SHIP side, but also on the FLEX side. We've used that needs assessment data for other types of consortiums. One of our biggest ones in Louisiana is Louisiana has been paying for a platform called carelearning.com, which I think a lot of our states actually participate in. And again, we use that to launch and share different training. It's a training platform that's used within within critical access hospitals. And so we have created, launched, trained, done training development across consortiums of CAHs based on specific needs. And then we launch that into Care Learning so that it can be shared across all of our critical access hospitals. And then we adapt and use that over time. So again, really leveraging that tool and working with it both on the FLEX side, but also on the SHIP side in order to move those SHIP objectives forward.
I'll piggyback a little bit off of what Rochelle said. Much like Louisiana, we've identified ways that we could get the most from FLEX and SHIP. So In the past, we've done ACO under flex, but because of course all the critical access hospitals are also SHIP hospitals, we've now moved away from doing ACO under flex, and we have this, like you said, just paying one vendor to do the ACO piece under SHIP. So all of our hospitals that were originally participating with ACO under flex are now doing it under the SHIP funding, which so far has worked out really well, because in the past it's always been done with the Mississippi Hospital Association. So we continue that piece with them, just using the funding from SHIP. Same thing with value-based purchasing. We originally done that under Flex as well with the Charters group, now doing that under SHIP with them. And that's been working out. More hospitals have been able to participate. More hospitals expressed interest in doing the value-based purchasing piece. So that piece has been working out really well. So just figuring out where the two programs overlap and where it makes the most sense to do activities under SHIP and not necessarily under Flex, and just kind of meshing those two together with all of the resources.
That's terrific. So there's a couple of things there that actually segue really well into our next question here, but we're all working towards how can we really make Flex and SHIP work more effectively together. I mean, that's ultimately at the end of the day, how can they be amplifiers or catalysts for each other is what we're looking at. But the beauty of this is that you do have access, like we're talking about through the Flex program, through additional data and evaluation, and like what do they need is what we're really digging for. And then once we have those things, if they fall within the parameters of a allowable investment for SHIP, it's certainly worth consideration, particularly if you've got a high frequency of health systems that really have a use and need for this as for consortium-based activity. So that's fantastic. The next question we had here was, what strategies do you use to identify needs and priorities for use of consortium-based funding? So if we can't get around the needs assessment, we can't get around, we have the access to data, whether it be retroactively a couple of years in the past or from the call we just got off with our hospital association based on what they just ascertained. But either way, identifying the needs is the starting reference point. And then from that, you can see, okay, how where's going to be the highest return on an investment that we can really tackle some better use of funds for a specific target population and need for our state. So both of those are fantastic. It looks like, Caroline, you have something you want to chime into?
So I did want to make one clarification. I think Rochelle misspoke. She said ed caps or ed caps for with SHIP fund. So Kate pointed it out in the chat that that's an unallowable expense in SHIP. That is correct. So
Good point.
there was a miss.
Yeah, oops, I
there.
meant H caps, sorry.
It's H caps, yes, H caps. So sorry to anybody that confused, but yes, it's H caps.
ED caps. Thank you so much for that clarification, Caroline. And yes, thank you for pointing that out. That's we as an example of something that potentially could be used through Flex and identify another high need that falls within the parameters of SHIP funding. That's certainly something that we can hopefully make those needs, we can tackle some more effectively through the SHIP grant and some more effectively through the Flex grant. So I think to Rochelle's point that that was a high need. It's a way to use funding to really throw a net out for multiple organizations to address that specific priority for them. So the same kind of principle holds true, about different allowable investment, but the same theoretical approach here for SHIP. We've got, are there any, and I'll put this out to the audience here too, are there any other approaches or what has some of our SHIP coordinators here, what are some of the things that you all use to identify needs that are really, this would impact many of our hospitals in this part of the state or region, or how do you determine that within a SHIP grant as far as a potential consortium-based initiative? Is there anyone else that has a opinion or perspective on how to go about doing that?
Well, people are thinking, I'm going to just throw out there this critical access hospital QI infrastructure survey data that's going to be coming out could be really useful in terms of SHIP funding, thinking about where some of the priorities and needs may be. So I'm really looking forward to having access to that data just to really supplement the needs assessment data that we collect as well.
Absolutely. That's a really great point there. So what that we were trying to sell this the reason why this is really going to help you in the future, not just legislatively for support, but also driving strategic direction of future funding. So great point, Rochelle, too. One of the things that when we were kind of putting together this webinar that came up was, surveys can address a lot, and they can really, when you talk about unpacking something and really getting specific to things, a brief survey, a questionnaire can really help you get clarification on what direction is best. And it looks like Mary's got something. Go ahead, Mary.
It's even breaking news because I got the email about 2 minutes before we started. So we run a consortium model with a single contractor managing it, and they do the needs assessment, and they do sort of a two-tiered approach. They work individually, our contractor works individually with each hospital, but then they pull them all together. And I just got a question about EMR implementation and money, and does anybody have any money for this? And what happened at our consortium meeting was that several of them that were struggling with the same software have decided to help cross-train each other. So they don't even need money because they're going to teach each other. So that's a benefit. I think that's a cool that's what happens when you bring people together. And both in SHIP and in Flex, I'm beginning to find out they talk a lot, that they meet in these consortium groups and they talk behind our backs in a good way, and they've been helping each other, and we're not measuring that. And I'm about to start trying to figure out how to measure that. How do you measure the collegial partnerships intra-hospital that your Flex and that your SHIP and your Flex consortiums create, which maybe where you're getting even more value and long-term than what we're presently collecting.
That's very interesting, Mary. And that definitely there's things that we that kind of ties back to the evaluation. It's like there's a lot of long-term positive benefit to gain that's sometimes difficult to quantify, or how do we actually get to that? Because we know it's doing impactful and it's good, but how do we go about telling that story? That's please keep us posted as you continue to have your discovery with that. We've got another question here. Okay, so how can the consortium establish clear performance indicators and metrics to assess the impact? So this goes to a little bit to what you were speaking to, Mary, as far as how a consortium can be framed around that. So I know we talk about outputs and outcomes a lot. We're in the middle of an evaluation series, but anyone have an opinion on that one? Looks like Nicole. Hey, Nicole.
Hi, I have a question. So if anyone wants to weigh in on that
Sure.
opinion first, I can wait, or whatever you'd like.
Go ahead. What everybody's thinking about here.
Okay. So I am curious. In North Dakota, we've traditionally worked under the approach of each hospital selects their own activity and does their own thing. The hospital application form has always had, the network consortium expenditures section on there. And I'm curious to know, has any other SHIP program ever had hospitals form their own consortium or network, whether it's only for SHIP or if it's something else, and do SHIP funds? Has any SHIP program had a group of hospitals come to them through the application, checking either one of those boxes? And then if so, like, how did you approach that, or how did you deal with it?
I'll say in Mississippi, we haven't.
Say again, Alicia's. I'm sorry, I couldn't hear.
That's okay. In Mississippi, we haven't had to experience.
Okay. And Nicole, you asking if they do identify as we would like to participate in consortium? How do you, what's the next steps from there? Is that what I'm hearing?
Yeah, so if myself as the SHIP program were to receive back, say, a handful of applications from hospitals saying we want to form a network, or maybe we're part of a network and we want to use our SHIP funds together, if they would come to me by checking one of these boxes on the hospital form, has anyone else been in that situation?
I can say that in Wyoming, we were in that situation. I don't know if it's currently in that situation, but we did have 3 hospitals come to us, say they proposed X, Y, and Z as a part of their SHIP activities and wanted to work on something together. Now, what made them unique, or not so unique with the critical access hospitals, but unique within Wyoming, was they were a part of the same system, and so they wanted to be able to work together as a part of their own consortium.
Okay, so then did you alter, what was the trickle effect to you as the SHIP program then? Did you change any reporting processes or anything like that, or?
No, because initially they were all individual grants that were going out as a part of SHIP. So in some ways, this, it really did streamline the process, given how complicated it is to get that grant funding out. So the only thing that really changed was on the data collection side, on the back end, that it was coming from one organization instead of 3 organizations.
It was it would seem that and I've heard this from some of our other coordinators here, and certainly anyone feel free to jump on the call here too, or in the conversation too. But it would seem like that. So if they're ticking this box to say this is a priority for us and we're open to a consortium, then there's your discovery or planning call network that you bring the all this subgroup together to say, okay, let's identify our priorities within revenue cycle collections or whatever it is that they're in their priority is. Let's have a little bit more defining what that looks like and what we have a consensus on. And sometimes they'll do a mixed weighted score where there's a lot of ideas that come out of that, but then you have them all vote on their top 3, and whatever ends up being of those has the most votes. That's what you orient your consulting services or bring in the an agency to help assist you with. It looks like Renee's got something here. Go ahead, Renee.
I was just going to add, we had the same thing. A couple hospitals in the same system wanted to. So I would say the only addition that I wanted to add is that on the back end, when you're doing your annual report, you would then say, they were a part of this group and this was the other. So I was like, honestly, it's not too much of a burden when they decide to kind of change in the middle of it. Just on the back end, I would say that was the additional when you asked what we had to change. That was it.
Thank you.
I hope I'm doing that right. If I'm doing that right.
You are. Thank you for that, Renee. Yes, and some would say that makes your evaluation component and reporting component easier because it's basically you're treating it like one entity. They're all saying the same kind of evaluation wise or deliverables. There's some continuity there. So some would say that it makes life a little bit easier if they're all within the same bucket. But one of the things that one of the biggest challenges we talk about with this and how you implement this is related to how do you get commitment from your hospitals to do such a thing. So we have a question here: how do you gain statewide support and commitment of the SHIP hospitals to ensure successful engagement throughout a consortium project? So certainly making it volunteer based, not that you can't, if you have the means and capability, say we're leveraging buying power of a dollar over here, and we're luscious approach. There's nothing wrong with that too. But if you there are states that have a mix where they say, okay, you have an option. You can if you want to be independent, that's fine. If you want to potentially get more bang for your buck, and you're willing to all go in on this activity, we can potentially have bring you more value through doing that. And as long as they feel like they have this flexibility, you tend to get people who are committed to being a part of that consortium and project, and really will want to be engaged. Looks like yes, excellent. Renee is good, a great point too. And Dawn, you had something to add here?
Yeah, sure, Nick. Hey, I'm Dawn from Georgia. So we do the split approach, and I think you wanted me to mention that we offer several programs through our SHIP program. We work with a hospital association and then another like Hometown Health, and we develop the programs, which we have three separate programs that we offer in SHIP. We have those ready prior to writing our NCC. And we also offer our hospitals the option of being a direct grantee to do their own programming. So we just started that in the current year, in this next cycle we're on now. And so thankfully our consortiums have been agreeable to just taking whatever they can get. And like for the hospital association, it's like a data visualization or data management program. We have 30 in that one. And then in the Hometown Health revenue cycle, we have 16, I believe. And then we have about 6 in a swing bed program. And then we have like 6, if I'm getting those numbers right, we have 6 direct grantees who are doing their own separate projects. So we give them a lot of options, and we found that works out pretty good for our state.
That's great, Dawn. Thank you so much. So that's kind of what I guess we were fishing for with identifying needs. Was the data tell you? Was your prior evaluation tell you here? And those are all whatever you would potentially offer as a consortium. All they're high value. It's really a matter of what's most meaningful to that specific health system. So genuinely, they're committed. It's something that's going to be massively beneficial to them to participate in. So let's see here. We got just a few minutes left. I want to make sure. Let me look over here.
Hey, Nick, I just have a question for everybody, because I think one of the biggest challenges in shifting from direct funding to critical access to the SHIP hospitals to away into the consortium thing is that the hospitals don't want to give up that money that they're getting, or especially if they're using it for an HCAPS vendor, for example. And how have states made that move from direct funding to pay for the HCAPS vendor, which now suddenly feels like a cost to the hospital, to a shift the thinking into this consortium? What strategies have states used in order to make that move? Because that's probably the biggest place where funding is still being directed.
I will say, in our state, making the choice to move from having the hospital as a direct grantee to the consortium, I did notice in the individual agreements that a lot of the hospitals use their funds to pay an HCAPS vendor. However, a lot of these hospitals are also critical access hospitals, which mean if they're participating in the FLEX program, you're already required to do HCAPS, and our vendor for that is the hospital association. So there would be no need to use funds under SHIP for HCAPS when we can just already complete this project under FLEX. So for the hospitals that weren't considered critical access hospitals and are only SHIP hospitals, I pointed out the benefits of moving towards, let us handle this for you instead of you paying an HCAPS vendor. Here's someone that is, really well known in the state, that knows, the needs of our hospitals in the state. Let's move forward with this consortium for, HCAPS, which I think falls, I can't remember which one of the allowable investments it falls under, but just pointing out the benefits of using the hospital association versus them using their own vendor. Because most of these hospitals that are submitting invoices, the invoices are way more than the funds that they're receiving individually out of the ship. So it's really not making that much of a difference. I think if you point out that the financial difference that it's going to make, I think that sold a lot of hospitals. Like I said, we did not receive a lot of pushback from our hospitals with this approach. So I think just pointing out the benefits was really good.
Yeah, that's a great point, Luscious. And that's to Rochelle, to your point, that's a you know, historically age caps, everybody wants age caps covered. And that it, you know, if it's an operational expense that it's ongoing and it's you know, that's something that's best addressed through their other activities that they're doing it, whether it's in flex or just a normal ops where they can really take a greater step forward through a more valuable consortium project than they would be otherwise by doing a patient satisfaction survey. Then that's or press gain or whatever, whoever they're working with. Historically, certainly selling them on the value of you're going to get more, potentially more return from this investment if you would be willing to, you know, leverage buying power with a group that also aligns with the same kind of needs that you have. Yeah, that's great. I did got one last question, and I don't know if Donna, be really interested to see how you come to this too, but so when it comes to identifying, here's the highest priorities for a specific consortium. We've talked about leveraging the quality assessment, inventory assessment just had. We talked about looking at the data you have available, and we've talked about sending out a survey and really getting their, you know, firsthand feedback on what would be highest value to them. But is there anyone else here in the audience that has a recommendation or approach they've used to identify what topics or what key objectives of a consortium or would be the highest value for your state? And thank you, Caroline, for launching our polling here. We've got just a few minutes left. And really that comes back to really building the relationships to hear firsthand from your hospitals what it is they need. You know, we can look at data that was reported last year, or we can, you know, but having that organic conversation with what is it they feel like would be most helpful to them, where are the pain points that Pareto 20% of where your states are really struggling the most in. You know, that's certainly tackling that through the SHIP allowable investments is through a consortium is certainly massively beneficial. So hopefully you all had a chance to you know, maybe learn a few things you didn't consider before, and are able to walk away with this with at least being able to initiate that conversation and brainstorm and think about what that might look like and what be maybe highest value to meet the needs for your state from this. So thank you all so much for being with us this afternoon. And unless anyone has any last minute questions, I think we can leave you all to your reporting and yes, all good things to come for the SHIP grant program. And with that being said, thank you so much, Aloysius and Rochelle, for being with us today. We greatly appreciate your time, energy, and effort. And thank you all for being really good, exceptional stewards of the funds and really being incredible advocates for rural health across the country. So thank you all so much. And with that being said, we appreciate you wrapping up the polling, and we'll see you next time.